Welcome to Healthcare Quality and Risk Matters, the show where we dive into the topics that matter most in healthcare quality and risk management. Wondering about patient safety, quality improvement, or risk mitigation, but weren't sure who to ask or were afraid to ask? Well, you're in the right place. We create a safe and judgment-free space to explore these critical topics together that will leave you informed and inspired to make a positive impact on healthcare and patient outcomes. So let's learn and grow together because healthcare matters.
Well, good afternoon, everybody, and welcome to Healthcare Quality and Risk Matters. My name is Gary Bierc. I'm the CEO of Aperitisoft Healthcare, and I am joined by my two esteemed colleagues. I've got Dr. Timothy Brown, who is our Senior Vice President of Customer Success, and Rob Santamoor, who is our Chief Operating Officer. Rob is our resident registered nurse. I guess it's hard to get that out, huh, Rob? And Timothy is our resident expert in healthcare administration. You can count on me for everything risk management, and that's why we've pulled together this panel to try to help you have a perspective from different angles of risk and quality, and to give you new insights that hopefully can help to inspire you in your own organizations to improve patient outcomes and so forth. This month is the first month back into a new year. This is starting our second full year as a podcast, and we want to thank everybody for supporting us. And those who are listening live online right now, we appreciate your continuous support. And keep giving us comments, guys. If you're out there, you can give us a shout where you're from. We'll try to recognize you from the audience. But also, please hit us with comments and questions throughout our podcast today. We'll try to address the questions the best we can. This month, we're talking about realizing synergy between risk and quality, or quality and risk, or however you want to say it. Basically, what we want to discuss is why those two aspects or those two disciplines need to be working together. And before we dive into the incident of the month, any of you guys have some opening comments as we start this year?
I'm excited for, I feel glitchy. I'm excited for this year's podcast. We learned a lot last year. And there's building on everything that we gained from the insights of our listeners and the comments. Yeah. And I'm really excited about that momentum. And to dive deeper into some of these topics and generate more conversation.
Yeah, awesome.
I agree. Yeah, same thing. I'm really excited about the conversations that we're going to have, not only on our podcast, but also with individual hospitals as they're starting to make that transition and change to connect both quality and risk together. I think this is going to be a switch that is coming. It's necessary, as we've known for years, but it's a switch that I believe is going to happen in this year. To start to build out what quality and risk looks like for an organization. So really excited about these conversations that we're going to have.
Now, for you guys who are new, have never listened in before, we tried to make it a little fun, the best we can. We opened our podcast with the incident of the month, followed by what we call Minute Matters. And Minute Matters means that when we throw questions at one another, we've got 1 minute to answer. So we don't literally have a gong, but we'll have fun with that throughout the broadcast today. But then we'll dive into Q&A near the end, and hopefully we have time for the last word, and we pass that around our group who gets the last word for this session. Also, we do have an after show. So when this is done, we're doing something new this year. We're going to have a live after show. So we'll give you more details about that as we get into the end of the podcast. So, Rob, let's get into incident of the month. What do we got?
So Becker Hospital Report's one of my favorite reports. No affiliation. I just love them. So shout out to them. There's going through trying to find one. What I noticed is this really significant trend of some negatives in the news around there's healthcare performance. That really speaks to that gap between quality and risk. And I just wanted to, instead of having a bunch of specific incidents, highlight the top 10 things that really stood out to me. There's seeing different headlines of horrible things happening in our healthcare system across the country ransomware attacks, strikes, doctors and nurses leaving bedside. There's because of working conditions. There's kickbacks, lawsuits. There's implementing tools like AI that are completely unvetted. They didn't go through quality and risk. They're just implementing things, and that can harm patient care. There's hospital ratings decreasing, poor patient experience, hospital and unit closures. So either units and hospitals closing or entire hospitals closing, eliminating care for everybody in the surrounding areas. There's horrible audit findings, such as immediate jeopardies. And of course, some very significant financial hits. There's to the healthcare system that quality pays back tenfold. But there is one that I wanted to highlight that I think speaks to quality and risk collaboration and synergy. And that is a specific hospital in Missouri had a Leapfrog A. So they were doing wonderfully. They had data to support they were doing.
At least per Leapfrog.
Per Leapfrog.
Yeah.
But there was a gap. And the gap was severe enough, just one gap. There's in the lab that created, there's training issues, poor quality control, and poor line of sight for oversight into quality in the lab, leading to an immediate jeopardy. A Leapfrog A hospital was cited in immediate jeopardy. That to me speaks volumes about quality and risk synergy.
Wow.
Yeah, it's almost like if you don't have synergy, you're not immune.
No, absolutely.
If you want to have a good shield against bad things happening, you've got to collaborate. Otherwise, you can have the legs knocked out from under you with no warning. It almost feels that way.
Absolutely.
You need the constant risk assessment, the constant quality improvement, the quality feedback loop. There's of those processes working in collaboration with compliance. There's in operations to make sure that those gaps are identified. The gaps are closed, and you're continuously improving and adapting to the world that you're in. And one breakdown, there's just one, might make it through several audits. It might make it through. There's even several small incidents, but eventually the gap is going to be profound enough to where.
Let me ask you guys. You're the hospital experts, okay? In a hospital, how would they define risk and a risk assessment?
So I'm going to try to be nice. So I'm just going to say poorly. We define risk as an incident or something very overt and in front of us, right? It's a very reactive.
So you're saying retrospectively?
Yep.
Retrospective, yes.
So risk is something that has happened or is about to happen. And the most proactive we get with risk in definition is a good catch or a near miss, which means we got lucky. Near misses and good catches aren't proactive risk management. It is luck. It's luck that something bad didn't happen.
Now, would you say, tell me this is true or not, I ran into this recently. It was with a fairly large senior living and assisted living organization, and they considered risk management to be insurance.
Oh, insurance and workers' comp.
Yeah.
Interesting. Yep, those are, you're right, your other branches of risk in healthcare.
Now, is that common in a hospital as well?
Yep, absolutely.
Unfortunately, yeah.
So if you have a risk management department, they're the guys buying insurance, worrying about OSHA.
Yep.
Right. And then the other risk management stuff may or may not be in their purview. It's probably more in quality, and that is incident management.
Mm-hmm.
And then after that, we're dealing with what? Compliance and dealing with managing audits when they occur. Is that pretty much it?
And I like how you separated those, because those are fully separate in a lot of healthcare right now, which is leading to these gaps that we see when you have these silos and no synergy, no overlap. there's end up having even our best performing hospitals, there's putting patients in immediate jeopardy.
So for our audience, just so they understand, when we're talking about risk management and we're talking about quality, right now in most hospitals, they're separating out potentially incident management, insurance management in one camp, and then they have compliance and interface with payers and quality metrics and so forth in another camp.
Yep.
And they loosely communicate.
Absolutely. Very loosely.
That's very nice of you to say, Timothy. Yes.
Yeah.
Right.
There's generally a wall.
Me as an enterprise risk management practitioner in outside of hospitals, they're all under the enterprise risk umbrella. And from the way I view the world. Okay. Maybe on that we should transition to Minute Matters, because I got lots of questions now.
Absolutely.
I love the questions. I know we have a quick, there's realizing synergy in healthcare quality and risk, just for a visual for our viewers.
Okay, why don't you keep that up? Keep that up. That's really good. Why don't you take a couple minutes, Rob, and just kind of go through this slide so that you're walking through for our viewers, what we're displaying here and what we're trying to say.
And for those that are not able to see this because you are audio only, there's the image is essentially a Venn diagram. There's explaining how quality and risk have to overlap and function. There's in order to have successful systems of operations and quality within your organization. So quality can be things like patient satisfaction metrics, clinical outcomes and improvement. There's an evidence-based protocol development, right? Risk can be incident reporting from the reactive standpoint. It can be regulatory compliance and audits. Those things can very much overlap and be similar functions with compliance. Risk assessments for malpractice and liabilities. There's where you can gather the potential for risks. But where it's important that they work together is the center of the Venn diagram, the synergy between the two of them, that allows for continuous monitoring of adverse events. There's seamless corrective action and preventative action, and enhanced data integrity and cybersecurity. So looking at them separately, if you're gathering metrics from a quality standpoint, but you're not incorporating any of your risk assessment, or you're gathering risk data, but you're not incorporating process improvements with quality, there is no continuous monitoring of adverse events. There is no enhanced, there's data integrity. The whole system falls apart. Gaps are created, and there's a cohesive system that's going to prevent the negative, and continuously improve, especially when hospitals need it most. We have no staff, we have no money, and we need to retain every dollar that we have and every staff member that we have. And the only way to do that is through synergy.
I would almost submit, guys, that we don't have room on that slide, but another thing that would be an outcome of the merger, the synergy between risk and quality, would be a proactive view of risk, and where hospitals can start getting ahead of events and actually doing preventative action before there was ever an incident that occurred.
Absolutely. I think it's important that quality is continuously improving, staying ahead. There's new changes in regulation, right? Closing gaps in process, ensuring the training happens appropriately, ensuring that we're growing. There's ahead of the standards, not after we have an audit finding. That we are doing really good risk assessments, and that we are correcting things and improving things before incidents happen. Not because somebody almost fell and died, but before somebody even almost falls and dies.
Yeah.
Agreed.
Hey, before we move into Minute Matters, are there any questions from the audience that we can throw at Minute Matters?
Not as of yet, but we do have a wide range of participants today. We have people from Omaha, Nebraska, Charlotte, North Carolina. I see Roanoke, Virginia, Syracuse, New York, and then also London, UK as well. So we have a wide range of participants today. So thank you all for joining us.
Yeah, thank you. Well, let's get into Minute Matters. Let's have some fun.
Yeah. So my first question is to Timothy, and I think I asked you this last
Sure.
year. There's you. I put you on the spot and wanted to know what the executive teams in hospitals believe quality and risk are, and why we value stream them in these separate functions. And I know it's a very vague question.
Okay. Same question?
Same question. Why do we put them in these value streams that we silo them and we don't ask for any, there's synergy between the two functions?
I believe there's this old world understanding that you work in your world, I work in my world, and we only meet when there's a problem. And I think that's the reactive nature of healthcare, unfortunately. I don't know why that is, but that seems to just be the understanding. You work on what you're focusing on, I focus on what I focus on. You can even see this many times when you see doctors come into a patient's room. Patient tells the doctor what's going on. They have what we call tunnel vision. They focus on that one thing, not necessarily looking at the full holistic patient. It just is the culture that we have bred in healthcare that our focus should be on treating the issue and not necessarily treating the patient. I think if we take that ability to kind of rework and refocus our culture, we can work to break down some of those silos, especially in quality and risk. They have a lot of synergies anyway, but for some reason we have identified them as two separate entities that should function on their own. But if you think about the lungs, the lungs and the heart, they're two separate entities, but without each other, the body cannot actually function. Same thing with quality and risk. They're both essential entities that should be working together to be able to create a whole full working system.
I love that analogy so much. As a bedside nurse, I know fighting between the different specialties, and there's renal wants one thing and pulmonary wants another, or neuro wants another. And if you let them act independently without considering the rest, guess what happens? The patient suffers.
The patient suffers.
I love everything that you just said. That was a wonderful analogy. We need to get that to our marketing team right away. That's a wonderful analogy.
Now, again, looking at this, Rob, I can imagine looking at what we bulletize as the separation of quality and risk, that the types of systems that they use are vastly different. Is that true?
I believe we're overstating it when we call it an actual system, because I'm not even sure it operates in a system standpoint. There's data fields, we have forms, things that we can fill out that separate those functions completely with no loop closure, no communication between the two in an intelligent way. So you're right. There's many hospitals that I've consulted with over the years. And that we all have consulted with and worked with. There's as a team, have a system function. There's where you have one team that documents in something maybe Excel based. Then you have another team that may also use Excel, but not the same Excel form. They also may just use a Marble composition notebook or Microsoft Word or Teams planner. There's no collaboration. There's no communication. It is whose job is it to take the next step?
What are these bigger systems? These bigger systems that are out there that we recognize our company that there is like Q-Pulse out there. There's Midas. There's RL Datix. What are they doing for hospitals? Why are they falling short?
Doing almost exactly that, right? You have these disparate functions. There's where you're transferring, there's the data from one point to the next at most. There's at the very most, you're just transferring it for somebody else to take over the work with no full loop closure mechanism, both in process or there's in technology design.
All right. So although they might claim to be integrated, they're not truly integrated.
They're not fully integrated because it doesn't allow for that full loop closure where you've identified there's something, either through proactive risk assessment, through there's an almost event, or through an actual event. There's added in the quality functions. There's to improve, and then that really important piece, measure, monitor, and maintain. Right? We're constantly monitoring it. We're constantly measuring all of our potential. There's in actual risks to make sure that we stay ahead of them through quality programming and process improvement.
All right. So to give some advice to our audience, if you're working with Datix, you're working with Midas, you're working with QPulse, don't let those systems restrict you from synergizing the different aspects of risk and quality that you need to do. And, if you're not looking to a software like ours, which does synergize those different things and integrate those things, at least attempt to build manual processes to allow for those things to flow together so you're getting the maximum benefit. This is where you can stave off what you described in the incident of the month, where somebody thought they were an A leapfrog rating, and suddenly they get the legs cut out from under them because their eye wasn't on the ball in this area over here, because there was a lack of synergy. There was a lack of cross communication going on, so that an issue like that could have surfaced before it became a problem.
Absolutely. And I like the advice that you're giving. Don't let your system stop you and keep you in a perpetual downward spiral, to be honest.
Well, I know that's common in many industries, guys.
It is.
It is. People allow the software to dictate their process rather than have the software adapt or follow your process.
So, Gary, that speaks to leadership listening as well. I've talked to many employees that work in quality, and they'll tell you my system, and they'll just frankly tell you it sucks. It does not do what I need it to do, in one form or fashion or another. So I think it's also leadership's job to listen and say, are there other systems out there that are doing what needs to be done for our organization? Have we looked and explored to see what's new, what's open, what's actually transitioning and changing quality and risk now? Because I think if you limit yourself to just using the same system, you lead yourself into insanity. We all know the definition: doing the same thing over and over again, expecting different results. If you're seeing that your quality is failing, if you're seeing that you're having issues reoccurring in your organization that should be prevented, it may be time to start looking and seeing if there's another system that's available. And I think Aperitisoft can definitely help you in the right direction for that.
Hey, we have a couple comments coming in from the audience there. I see Lakeisha is talking about fragmented data systems.
That's correct.
Absolutely, Lakeisha. I mean, I think that's the point being made here. And then you have Ritu. I think they're falling short because of a lack of true problem solving.
Fully agree. And I think it's a lack of problem solving on both available systems there's the hospitals and healthcare in general are currently using, and from hospital administration, the decision makers. There's solving the problem isn't just throwing another gap filling compound on the crack, right? That's not how we're going to solve the problem long term. That's barely a band-aid. We know that something's going to happen, break through. There's kind of go off on a tangent based on your comment. I've worked with really terrible systems in the past that did not help my organization. Build better systems of overall quality. And I hired a lot of people to fill the gaps. Mm-hmm. And although our system of quality improved, I designed all of these people-driven processes. I was dependent on people in their seats, in their roles, on their computers. And that is, one, a lot to put on somebody's shoulders. And two, there's honestly poor operational design on my part to expect there's a human to do what we have technology in this world to do, right? And I think a true problem or a true solution is a more intelligent software, a more intelligent tool
So, yeah, and that's allowing the tool to make it easier to synergize, right? That's what we're trying to say.
Absolutely.
And Dave,
What does Dave have to say here?
it appears you are focusing specifically on hospitals today. In that area, one of the opportunities for integrating quality and risk would be to enhance communication with patients by a post-discharge team with direct support by community services as needed and integrated feedback there's flowing back into systems. Absolutely. So everything from there's transitional care management to things that work well post-discharge to those quality metrics that we're monitoring. There's for both our payers, for CMS, there's for our basic regulatory functions, right? All the HEDIS measures that we're tracking. There's on a continuum and having a feedback mechanism into quality systems so we can evaluate how we're doing and closing all of those care gaps that we often see created, unfortunately, universally, right? There's our post-acute care systems in the United States are just not good. So supporting community services and having really good data as to where to allocate those funds, those resources to close those quality gaps. Fully agree with you, Dave.
Yeah. I will say I love this comment that Dave gave because it speaks to having the right data and the right technology to be able to get this information into the hands of patients. I think where we fall short is it's not the fact that the patient doesn't know, it's that we don't inform them, we don't give them the information that they need to make those changes. And then stay up with them. That's what the post-discharge team does. They help the patient once they're discharged from the hospital to hopefully not return back to the hospital. That's generally their overall arching goal. However, they aren't given the information sometimes, or sometimes patients are just discharged and you never hear from them again until they're readmitted. So
that's not okay.
I think it's definitely not okay from a standpoint of a healthcare system because they then become that patient that is readmitted multiple times, and they can drive up the overall bills for the organization as well. But there is a role that data and technology plays in driving that synergy to get that information to patients, to get that information to all departments that need it, and that have access to it. And I think you need a system that can that's smart enough and intelligent enough to be able to get that information to the right participants.
We've got a little less than 3 minutes left, guys. I got a couple things that I think we should bring into the discussion. One, I mean, we run into it all the time. You go into a hospital and like, yeah, okay, I get it, guys. I need integrated systems, which Aperitisoft Healthcare can do. But I'm working with Midas. But I'm working with QPulse. But I'm working with RL Datix. What my recommendation to everyone is, look, we're certainly willing to work with your health with a healthcare organization to make sure that if necessary, both can be working at the same time. If you're using one of those systems as a larger group aggregator, you can still be able to use an integrated system like Aperitisoft Healthcare or your own manual systems to be able to get data in there and allow that to go up. But don't lean on that technology to drive what you're doing. Run a synergistic risk and quality system first. Use the technology to fill in where you need it. And if you need more technology, like what we have to offer, or maybe others have to offer, seek it out. It's going to make a big difference. And that leads to the second point. All of this gets down to financial waste and abuse. And we've talked about it multiple times. The cost of quality is very expensive, right? Of poor quality. The cost of poor quality is very expensive. It could be anywhere from $15 to $45 million a year being set aside by a 150-bed hospital. And yet they're struggling with, I need a new set of surgical equipment. I need a new wing. I need a new center for treatment.
And I need to be able to pay my staff so they don't keep going on strike.
Right. And the money is right there. It's right there under their nose. And it's in this cost of poor quality that's just being accrued year after year.
Yes.
And often overspent, that is available for them if they would take a synergistic view. You can start chewing away at those expenses and start putting them in the places where you really need it. So I actually took the last word from you guys.
Like it was great.
So we are out of time. Again, thank you for participating. Where can we go for the after show, guys, after we sign off from this podcast?
I'm actually putting the link in the chat now for everyone to join us for the after show. We are going straight to YouTube. So I'll put the link in the chat and also post it on LinkedIn as well for you.
And we'll probably be there within less than 5 minutes, everybody. We want to thank you for participating. Your support is what makes this podcast possible. Please share it with your friends. Get as many people as you know involved. We do this every month. Next month, we're going to talk about proactive versus reactive. We touched it a little bit earlier in our conversation. This is a pet peeve of mine. I don't know how healthcare organizations could potentially succeed if they're not being proactive. So we're going to tackle that topic next month. What day would that be on the calendar, guys?
Next month, it is on the 26th.
The 26th of February. So mark your calendars, please, and we'll see you next month. Thank you for signing in.
Thank you.
Yes.
Bye, y'all.
Take care. Bye.